Joachim.
Right, well, great to see you, Joachim, Duane, Robert, and Ian. So we'll just see all our...
We're just missing...
so we've got
Zhao.
Robert. Hi, Robert.
He's
coming. We're going to get you, Zhao, hopefully come in via Zoom in a minute.
Well, he was in that last session, as you could see.
Ian in Oxford. Hi, Ian.
He entered in the last session, and he was on the spot of Muller.
Oh yeah, I saw him. Yeah, that's right.
So that he was not connecting with the right number that I gave him. I will try to invite him now. Okay.
Okay.
There was a small suggestion from the viewers that the video, in spite of they trying to go on the spot option, they were not able to see the video on the full screen. Is there some adjustment at your end which also you are doing?
No, there's nothing what I can adjust, because I'm just like any participant going into your Zoom. So it's
Meenesh
a local
and everybody
connection.
and everybody listening. If you're on Zoom, you can right-click onto the small image and then go on to Speaker View, and that will make it full screen if you're on Zoom. If you're watching on YouTube, there's nothing that you can do, and there was definitely a problem at the beginning of the session earlier this morning, but that seems to have been resolved as time has gone on. So hopefully that will sort things out for most people. I wonder if we should start now with the presentation, okay?
Yes. Juggling here.
Yeah, I'm sure you are. So if
okay, there. Okay.
Okay, so we're just running a video now. So I'm going to talk a little bit about different ossiculoplasty techniques. It's a great pleasure to be able to be in this session. And one of the questions is, why bother with surgery when results are variable? Air bone gap of less than 10 decibels is difficult to achieve, or not that common, and results are often not that stable long term. Surgery is technically challenging, but we enjoy that. But the other thing we have to bear in mind that the hearing aids are improving. They're becoming smarter, more smaller, and more comfortable. So many of the patients we operate on would benefit with a hearing aid. We need to think about what affects our results, and although we think a lot about surgical skill and prostheses, the actual ear condition itself is probably more important in terms of eustachian tube function, infection, and ossicular status. And I think we don't want to overemphasize our inabilities. So I usually perform my surgery per canal. I use a speculum holder, and this is the Yazagil speculum holder, and it's really rather nice because it holds the speculum firmly, but it does allow you to move it. So it attaches to the side of the patient. There's a wire that you can tension that makes it go stiff, and it gives a very nice platform for you to rest your hands, so it can keep you nice and stable. So all my surgery is done per canal with this speculum holder. So the first case we're going to look at is an erosion of the incudostapedial joint, which is a very common problem. And some time ago, I used to use cement for it. And here you can see a fractured long process of the incus. I tended to use a laser to dry off the mucosa to make the bone nice and dry. And then I'm going to show you some Biosem cement. This is an Ion America cement. Very nice to work with. It has a little bit of a longer snap time than some of the other cements, and you can make a nice new incus. But I found over time they tended to fall off, so I stopped using cement. But more recently, colleagues of mine have persuaded me to try Otomimics, which is a hydroxyapatite cement. It's slightly more difficult to use than the Biosem because it snaps a little bit. The snap time is a little bit quicker, so it goes hard quite quickly. But I think the long-term results are meant to be better with this. So with a very small erosion of the tip of the incus, I'm sometimes tempted to use cement. You can see here, as the cement sets, we can gradually sculpt it to make a nicer looking reconstruction. And then once it's in place, you really need to leave it for a good 10 minutes before you start fiddling so that you don't get any fractures in the cement. I know Duane uses a lot of cement. I can see Zhao has joined us, so that's great. What I tend to do more when I have a stapes present is use a Dresden partial clip prosthesis. And this has got a very nice clip on the end made of very thin titanium foil, and it allows it to slip onto the head of the stapes, but once it's in place, it's very stable. It has to be orientated correctly, and I was introduced to this clip by Professor Grollman. So you can see there's a little marker on one of the arms, and that has to line up with the stapedius tendon. And we can gently push that prosthesis onto the head of the stapes. Here's another case. This was an atticotomy. The incus has been removed, and we're looking right down on the right here onto the stapes. And you hold the prosthesis with a sucker in your left hand, and then you can gently rotate it to get it into the right orientation with a needle in your right hand. Now, this prosthesis is really pretty easy to place. It's just, once you've got it lined up properly, you just a little bit of gentle pressure, and the foil clip opens up very nicely. And then, because it's titanium, we put a little bit of cartilage on top. So here you can see cartilage. This is also a reconstruction of the attic and the drum, and that just sits nicely in place. And I've found that compared to other prostheses, this is much more stable long term. This is a combined approach tympanoplasty. You can see the prosthesis sitting very stably on the head of the stapes. And again, I'm covering it with a little bit of cartilage. The advantage of a combined approach when you are in this situation is that you can have a very nice view from behind, either through the attic with a telescope, or if you perform it through a posterior tympanotomy, and it allows you to see that the prosthesis is nicely in place. Now, if I don't have a stapes, I tend to use a total prosthesis, and the one that I use most frequently is the Kurtz titanium variac prosthesis. This has got a platform which moves up and down, and there's some wells on a plastic former which allow you to adjust the length precisely of the platform. It also comes with some little plastic dummies which you can use to size to make sure you get the right length. So here's a dummy being placed between the stapes footplate and the tympanic membrane. You then choose the length that you wish here, 3.75 millimeters, and the prosthesis is placed into the well and the shaft pushed to the bottom of the well. There's a little bit of bent titanium which you straighten with a special crimper, and that nips tightly onto the shaft of the prosthesis. The excess is chopped off, and you now have a bespoke 3.75 millimeter prosthesis. Now, this is a little crimper that allows you to put a groove into the head of the prosthesis if you wish to place it underneath the malleus handle. I don't usually do that. I usually go straight to the drum, but if there's a well-placed malleus handle, this is quite a nice technique. And it basically allows you to put this quite nice deep groove, which can then sit underneath the malleus handle. The prosthesis is then placed down onto the footplate, and in this case I've got an omega connector which sits on the footplate. It's a little ball, and there's a socket at the base of the prosthesis that sits like a ball and socket joint, and it allows for a little bit of movement without the prosthesis being displaced. And then we can put the little groove underneath the handle of the malleus. So that's the prosthesis I tend to use most frequently. The problem with total prostheses is footplate stability, and I have used the Omega connector, which I think is helpful, and occasionally I use the Dornhofer shoe. This is a titanium shoe that allows the prosthesis to sit somewhat more upright. Here you can see the Omega connector that we just saw before, a little ball with the prosthesis sitting on top of it. This is the Dornhofer shoe, which allows a more upright orientation of the prosthesis, which sometimes, if the orientation is correct, is very nice. It's quite stable, and as with the Omega connector, sometimes a little fiddle to place onto the footplate. But once it's in place, the prosthesis, in this case Kurtz prosthesis, but it also works with Grace Medical prostheses, can sit directly in it, and it allows it to stay upright. So you can see it here just sitting underneath the drum. So I'm going to have a little look at a case now. It's a 36-year-old lady who, when she was 19, I performed a partial prosthesis using a Kaus Porp Flex 8 shape prosthesis. Now, this is a prosthesis I used to use where the shaft is made of a mixture of Teflon and hydroxyapatite, and it allows you to cut the prosthesis. And in this case, I was cutting it into the shape almost of a clothes peg to allow it to sit neatly over the head of the prosthesis. And this lady did very well for about 15 years, but over the last 2 years her hearing's gone down. And here you can see the prosthesis. It's hydroxyapatite, it's under the drum, doesn't cause much of a reaction to the drum, so it sits very nicely underneath the malleus handle. And when I lift up the drum, you can see that it appears to be sitting on the head of the stapes, but I thought initially maybe it's just a little bit too loose. So I dissected it out. I was slightly worried that bit of tissue might be the chorda, but I don't think it was. So subsequently removed the prosthesis, and I thought it was probably time to replace it. So we just gently take the prosthesis out. You can see the little closed peg shape that I'd made. And now we're looking down at the foot plate, and you can see that the anterior crus of the stapes is completely missing. So I decided what I would do here is treat this as put a total prosthesis down from the drum to the foot plate. So I was going to use a Vincent Alto Grace prosthesis. Wilco, can you be quiet? And this is a prosthesis which comes with some dummies which slide neatly underneath the foot plate. It was devised by Robert Vincent, who I'm sure we'll talk about it later. One of the nice things, it works very well if you've got a malleus handle over the foot plate, and Robert tends to use it with malleus relocation. But in this case, you can see the malleus is well placed. And you can adjust the length of the titanium shaft, and it allows you to put it in, and then you can readjust. Once you've got the right length, you clip off the excess. And you can see it's got a hydroxyapatite head with a deep groove. There's a rubber band that you can use if you have a stapes, but I was not using that in this case. And then it's placed directly from the foot plate up to the central groove sitting underneath the malleus handle. And that's really quite a nice stable assembly. So if I've got a well-placed malleus, I tend to use that. And then we just gently replace the drum. And then finally, I'd like to look at the situation where the malleus itself is missing. And again, I use a prosthesis from Robert, this time from the Kurtz company. It's the malleus replacement prosthesis. And this has got a Y shape with two arms that are placed into the scutum. You drill some holes right through the scutum and place the two little wire arms through those grooves. Then there's a Y connector, and that's very flexible, and it allows you to manipulate the neo-malleus, the titanium neo-malleus, to a position directly over the stapes foot plate. So when you've got no malleus, which obviously is a relatively unusual situation, this is quite a nice prosthesis. So you can see I've drilled the holes through the scutum here, and I'm gently pushing the prosthesis until it becomes snug up against the bone of the scutum. You see I push it nice and flat now. And over time, you get soft tissue and bone that forms in those holes. And then you can place, in this case, the Vincent Alto prosthesis made by Grace directly under the neo-malleus and down onto the foot plate. And that's nice and stable. The problem, of course, with the titanium, you really do need a little bit of cartilage just sitting over the prosthesis. So we take a thin sliver of tragal cartilage and just put that between the drum and the neo-malleus. And then we pack, and I normally pack with Merigel directly onto the tympanic membrane. So that's the end of my presentation, just showing a few different ossiculoplasty techniques that I use. And I'd like to hand over to you, Zhao, now as the chairman, to take us through the session.
Thank you very much. Welcome to, ladies and gentlemen, welcome to 9. Very much. I'm sorry for coming late because the link doesn't work for me. I'm so happy to be here, and my great honor to be chair of the session. And thank you very much for your video for the ossiculoplasty surgery. I should have to say I'm sorry because English is not my native language and mother tongue, so I will try my best to do it. So after the video, we can discuss something about our topic about ossiculoplasty. I think today we should discuss something about the processes and what the materials to use, the tool and approach, and the techniques for ossiculoplasty. I hope everyone of our distinguished and popular surgeons could have your best idea for this topic. Thank you.
I was just going to tell you there's a poll result which you may have seen, which shows that the Zoom audience are split 50-50 between autologous bone and a prosthesis, usually titanium. I'll stay out of it after that. So.
No, that's fine, John. Maybe we should go around and ask everybody what they do in the presence of a stapes. So a reconstruction with an absent incus in presence of stapes. What do you do in Beijing?
I'm not in Beijing. I'm not. I'm in.
Sorry.
I'm in Chengdu.
Sorry, in Chengdu. Sorry, I apologize.
Yes. The southwest China. For staples, we use Robertson staples and pistol. Sometimes we use the Omega shoe, but it's rare use because when we use the top, we usually use adjustable prosthesis or fixed length prosthesis of.
So what do you use when you have a stapes? What do you do when you have a stapes? The stapes is there, but the ink is.
We use pop.
And what sort of pulp do you use?
Grace for me.
Grace.
But I know we in Chinese we use cruise extra.
Okay, and Ian Bottrill in Oxford, what would you use in the presence of a stapes and an absent incus?
I would use the Dresden clip like yourself. I've tried various things over the years, and the thing about the Dresden clip is it's relatively bulletproof. It's a very easy and very stable prosthesis to use. The malleable titanium flanges sit nicely over the head of the stapes, and it's the sort of thing that you can quite easily teach your registrar to do. So I've found that to be the most stable and reliable, and it gives me the best surgical results in the long term.
Okay, should we go to Joachim? So you've got a stapes, it's mobile, but you've got no incus. What do you use in Munich?
Hold on, Joachim. We hear your speaker coming back very badly.
My speaker? Wait a moment.
Yeah. We hear echo from you. But anyway, you're on. Okay, go. Yep.
Good morning. Bonjour. Well, what we use, if the stapes is present, also depends a little bit on how the tympanic membrane is reconstructed or looks like, and if there is a remnant of the malleus or the handle of the malleus. In case of a classic chronic ear disease, no cholesteatoma, maybe the incus, if available, would be an option. Otherwise, we would go for a titanium prosthesis, and we have a one also manufactured by Kurz, which has a little bit of a rounded head plate to avoid penetration through the cartilage if it's placed under a cartilage tympanic membrane. However, there was in Chris' presentation a nice one which had a little handle to be put under the handle of the malleus. That's what our prosthesis does not have, and in these cases also the reinforcement of the tympanic membrane with cartilage should be paid attention to, so that the cartilage is directly placed aside of the handle of the malleus and not deeper and not thicker than the thickness of the handle of the malleus. But we definitely would go for a PORP prosthesis. However, if the stapes is more bended towards the promontory, a TORP prosthesis is also a choice. Not as nice as Robert's with the silicone bending, but we work on improvements on that.
I think we'll come on to Robert in a minute because I know he has a different view on it. So maybe Duane, if you can tell us, what do you do in Johannesburg?
So Joachim mentioned an interesting thing, the toppled stapes. If the stapes are sometimes toppled over and leaning against the promontory, that's a little bit tricky. But normally we would use, in these cases, we would use the Alto band with the Solastic banding, the Vincent one from Grace Medical, and actually relocate the malleus. Sorry, I hope I'm not stealing Robert's thunder. I've big influence from the French school, and I'd relocate the malleus and do a torp from footplate to malleus with a Solastic banding around the stapes. We are doing, in some cases, ossicle cement with a nylon core, but that's only if it's very favorable position, and in fact, the stapes is leaning over. Sometimes you can correct the stapes and use the cement with a little nylon cord to put it back into position and attach that directly to the Panelist.
Getting a bit of an echo from you at the moment, Duane. So we're going to go to Robert now.
Yes.
And Robert, I think maybe you could explain your
Duane,
technique,
it's not
because I think for many people listening, it will be something new.
Can I just one word before?
Yes, of course.
It's important because I think the echo that we have is related to the fact that we keep our microphone on, and then the sound comes back like this. So I think I will ask all of us if we don't speak to
mute the microphone. You're absolutely right, Robert.
Yeah.
But I can see that the sound is coming from Joachim, and I'm already squeezing his input once in a while. But then if he talks, we cannot hear him. So Joachim, if you can solve that, I can leave your microphone open from here. Otherwise, I have to close it every time, and you have to indicate that you're talking. Okay, that's it.
Yes. So I will. Chris, the microphone is off. So. Can I speak?
Sorry,
now?
yeah. So you tell us about your technique. So we've split so far, but most people are using some sort of partial prosthesis onto the stapes. So tell us about your technique and why you don't do that.
Well, you know that I was using porps in all cases when we had the presence of malice and stapes in the past, and then I move on from porps to torp exactly for the reason what you showed on your video clip, which was a very nice presentation, where you show the porp which was on place, on a good position, but with a little bit of a losing effect, you know, when was not attached to the stapes head. And I saw that in many cases in the past, and I was wondering how to increase that, and I moved from the porps to torps, following in one sense some previous publication like our friends from the US who moved from porps to torps. In case of, despite the presence of a stapes arch. And then I moved to the, so I did that, and I moved to the use of the silastic band to try to find, that was Bill Moretz who moved from porps to torps. And I was then trying to increase prosthesis stability with some trick. And I found this trick of silastic bending to attach the prosthesis to the stapes arch. Of course, you need to have a stapes arch, a present stapes arch. And then by doing this, you decrease the risk of tilting because the prosthesis stays well attached to the stapes, a bit like this. That's what we have. So you see the connection of that. We have the prosthesis, which is placed underneath the malleus handle, or if you don't have a malleus handle, then once you have a stapes is fine. And then you have this prosthesis, which is attached to the stapes superstructure by the silastic band like this. And by doing this, of course, you attach both together, and they are working like, I would say, single unit. That was the point. And then I was able to publish my results comparative series between porps and torps when using silastic bending. And I got much better results, statistically significant with the silastic bending. That's why I moved from porps to torps.
Okay. So John, I don't know if have you had a poll question about whether we use a torp or a porp in the presence of a stapes? Is that a question?
Yeah, the general feeling is that most people use a porp. 2/3 use a porp and 1/3 use a torp.
Okay. So Meenesh,
can I pass in my small experience of this? Well, I come from India. Now, with a genuine problem is that the Vincent's band or the titanium prostheses are expensive. So not all patients here can actually afford it.
Yeah.
So I have a series of about maybe more than 400 cases where I did it with autologous incus.
Yeah.
It was tough, but I had to do it because that is the best thing we had. And it worked. But again, in the last 2 years, I'm using a torp with the silastic banding. The difference which I'm seeing here is that with the silastic banding, if the patient is affording and using a torp, the airborne cap closure is much better than even a porp or a repositioned incus. But sometimes we have patients here who are actually not happy that they have paid such a lot for the prosthesis and it still extrudes out, or the result is not good. So it's a different problem sometimes.
Yeah, and if we go back to Zhao now in China, do you ever use autologous incus? Do you sculpt the incus in China? Do many people do that?
Actually, in my practice, we use titanium prosthesis usually, but sometimes, especially before we use the incus or the autogenous bone to reconstruct the ossicular chain. But we find that there's some shortcomings. For example, in the second look surgery, we can find the autogenous bone fixed tightly with stabias, and sometimes even fixed tightly on the promontory or on the facial nerve canal. So this makes the conduction poor. So from then on, we prefer to titanium prosthesis. It's more expensive, but most people in our hospital can afford it.
Okay, so if you have that with the ankylosis, what do you do about it? So you go back for a revision case, and the autologous incus is ankylosed to the head of a mobile stapes. What would you do about that?
You mean we fixed on the I cannot mobile?
Yeah, so you go back and it's a revision case. The prosthesis, the autologous incus is not working. Maybe it's too short, but it's actually fixed to the head of the stapes as you described. That's a very, very difficult situation. What would you do with that?
So we will try to separate it, but it's challenging when separated from the stabias. We sometimes use laser to separate it. Sometimes we use very small drill and drill it with very slow speed to separate it.
That's great. Can we go back to Meenesh now? Because Meenesh, you use incus quite a lot. Is that an issue that you see with ankylosis, where you do revision cases and the incus is maybe ankylosed to the posterior canal wall or to the promontory, or just ankylosed to the head of the stapes and it's not giving a good result? And how do you deal with that?
Well, what I have realized is that sometimes when you reposition the incus between the stapes suprastructure and below the malleus, it works initially, maybe for the first couple of years. And then there is a mild ankylosis amongst the autologous bone with the ossicle. So the patient has some amount of hearing loss, which gradually increases as time goes by. So in these cases, then we don't have much of a choice, but we have to remove and try to explain to the patient that he needs a prosthesis. That's the best possible thing which we can do. But it occurs in my experience in about 10% of the cases I've done, but not everyone.
Okay, that's great. So can we go on to Ian now and ask? We've used a partial prosthesis. It's got a titanium head. What do you do about cartilage covering, and what cartilage do you use, and how thick do you make it, and do you cut it? Perhaps you could just tell us that if you unmute.
I would put a cartilage disc over the top of the prosthesis if I'm using a titanium prosthesis, and I would cut it to about 0.5 millimeters. It just needs to be a thin sheet over the top, and it needs to extend to the full margins. And I think the other thing to point out is that no matter what the prosthesis is, these patients do very well if they've got a nice deep middle ear cleft and they've got a ventilated middle ear cleft. I think where you've got adhesive otitis or progressive retraction, then these procedures, whatever you do, are not going to be as successful. So if the eardrum is in good position and the cartilage is covering the head of the prosthesis, then it will prevent extrusion.
That's great. Well, that's a very good point about the condition of the middle ear. So maybe we could take that over to Joachim Muller and ask what he tells his patients preoperatively and how he decides which patients are going to be good to operate. What are the features of the ear beyond just the ossicular status, Joachim, that makes you decide whether to operate or not? So what are the factors that you look at in assessing a patient?
Well, the most important factor to look prior to surgery at is if the patient can do Valsalva maneuver and we have a chance to get aeration afterwards. And most of the patients come in with a CT scan, so to see the ventilated middle ear space and the ventilation through the Eustachian tube is one of the important factors to look at, aside of any inflammatory disease in the mastoid. Also nowadays
so
we can...
Just say, Joachim, let's just say that the middle ear is poorly ventilated and the drum's a bit retracted. It's not a very good middle ear space. Do you do anything to the eustachian tube or to the nose in sort of trying to prepare your patients to get a better middle ear ventilation? Or do you just say we're not going to do well?
We do the Eustachian tube manometry and measure the pressure for the opening as it was described by Sudhoff. However, in some cases this is reliable and we do Eustachian tube dilatation 3 months prior to surgery. But in the end, we will end up under surgery with the decision what to do, and if we have air in the middle ear ostium of the Eustachian tube. And then we have to decide whether we do a flat drum or a prosthesis. And as it was mentioned from India, we have colleagues who hardly use no prosthesis, and they always create a flat drum with a classical type 3 tympanoplasty with the cartilage on top of the head of the stapes, which also audiologically works nicely. And this is something we should keep in mind if we have poor aeration of the middle ear, that the classic type 3 with cartilage tympanic membrane gives also good results.
Can I just ask if you find the eustachian tuboplasty useful? Is it a helpful thing to do with the balloons?
Well, we have nothing better at the moment, and if it helps in 50% of the patient, this is a good thing for 50% of the patient who would not have a chance without balloon dilatation.
You think it helps about 50%?
Roughly,
can I ask the rest of the rest of the panel whether they do that? You, Zhao, in China, do you do eustachian tuboplasty if the middle ear is not particularly favourable as a sort of preoperative workup?
I'm sorry, you said
do you use balloon tuboplasty?
We use the balloon for eustachian tube just for the dysfunction of the eustachian tube for some otitis media with effusion and adhere otitis media extra. But we do not use it routinely in advance of the tympanoplasty or ossiculoplasty surgery. And sometimes, for example, when we have tympanoplasty surgery for type 1, before surgery, maybe the patient have not good eustachian tube function, but when we repair the eardrum, the eustachian tube's function can recover by itself, we think. The eustachian tube is not routinely before our middle ear surgery.
Okay, I think we're going to go to Ian in Oxford now. If you can give us your thoughts on the role of the eustachian tube. You mentioned that if the eustachian tube functions poor, then it's likely your results from ossiculoplasty will be poor. Is there anything we can do to improve that?
I think that certainly for trainees who may be listening, I think it's very important that any patient who's going to undergo chronic ear surgery actually has a nasendoscopy and looks at the postnasal space in the eustachian tube. I have a secondary referral practice, and it's not uncommon to look in the back of someone's nose and see that they've still got big adenoids even in an adult. And so I think you can remove the adenoids if they're obstructing the eustachian tube. You can also see if there's active sinus disease with mucopurulent discharge running over the eustachian tube. So I think those two areas we can address to try and improve eustachian tube function. I personally don't perform eustachian tuboplasty, but my understanding on the literature, and I'll be happy to hear from the panel if they know otherwise, that those patients who are adult with established chronic adhesive disease are the least likely to benefit from eustachian tuboplasty. So I take Joachim's point that if it makes a difference, then great, but I would certainly guard against the potential of moving these patients from an obstructive eustachian tube to a patulous eustachian tube, because I see that in part of my practice as well.
We're going to go to Robert now in the south of France. Now, for those of you who haven't been to the Caus Clinic, the South of France is in a very sunny place, and Robert's ears always seem to have beautiful ventilation, but I'm assuming they're the ones for the course. And there must be occasions, Robert, where you see your patients preoperatively and you think the drum's a bit retracted, maybe the middle ear ventilation is not so good. So how do you deal with that? And are there many cases where you say, really, we're not going to be able to operate here?
I don't think there is any perfect way to improve that. I didn't, with experience, I didn't see any really clear possibility to improve that kind of things, even the tuboplasty. So we try to, the first time I see a patient with a retracted tympanic membrane, before making a decision to operate on, I follow him and I ask him to come back and see what's going on with the retraction over time. I would say at least 1 year. And if it's a progressive retraction, like an adhesive retraction tympanic membrane, I don't think it's going to work. So for me, sometimes it could be a contraindication, except of course if we go for cholesteatoma. We have some tricks in France. We send patients to physiotherapists to do some physiotherapy, which is something special, using a way of using the tongue and things like that, and in a very specific way. And I must say it works well for some of the cases, but not always. But I don't have a magic. Maybe we could ask Duane to find a way for that.
And what about for his magic? Yeah. What about the tympanic membrane and strengthening the drum? I know you use hydroxyapatite, so routinely you're not using cartilage. But
No.
do you use cartilage much if there's a bit of a retraction onto the incus?
Not really, in fact.
No.
I don't like too much using cartilage, because I of course you have to trim it, and if we trim it, it's fine. But I've seen so many cases in which the cartilage was not well trimmed, it was too thick, and decreasing the efficiency of the reconstruction. So I don't use it that much. But of course, sometimes can help. If you have a severe eustachian tube retraction, I think you can do that. But
So one of the questions that's come through the Zoom room on that, following on from that, is what is the extrusion rate? We're going to go around the panel in a second, but what's the expected extrusion rate of their prostheses? So we'll start with you, Robert, because you're on the screen.
Okay, that's fine. I don't have the percentage here. I can check on my database if you want in a minute, but it's pretty rare, because the hydroxyapatite, I'm using hydroxyapatite, which is very close to real normal bone. So the extrusion rate is very small. I don't know exactly, but it's pretty rare now. But I have.
And what about ankylosis of hydroxyapatite? Because it is like bone, and like incus, it can ankylose.
Yes, that's right, but not to the stapes. It does ankylose
Sure.
to the bony canal wall, but that's important to give some gap between the prosthesis head and the bony canal wall. That's important to leave room for that.
Okay, we're going to go over to Duane now. So a couple of questions for you, Duane.
Okay.
So we were wondering about extrusion rates. What do you make of extrusion rates in China?
So again, we'll quickly check the stats. But in the early days, when I used to use torps directly to drum or something like that, I was getting a lot more extrusion rates. I can't quote a figure on by hand, but since I've been mobilizing the malleus handle and relocating the malleus, I always put a torp under the malleus. It's difficult if you haven't got a malleus, but I've now been using the MRP, the replacement prosthesis you showed in your talk, Chris, and I'm getting lovely results with that as well. So I'm always relocating the malleus, and I always put, if I'm going to do a torp, I'm going to put it under the malleus. And in this case, we also use the Alto band, the Alto prosthesis, so it's the hydroxyapatite. I have not had, as far as I can remember, certainly in the last few years, an extrusion. I stand corrected, there might be one, but the extrusion rates are very, very low, now that I'm protecting the drum with the malleus.
What about management of eustachian tube dysfunction preoperatively in terms of sort of trying to improve function? If it's poor,
so I've got to be honest. Yeah, I've got to be honest. I haven't been convinced about balloon plasties. Although we do them for other indications, we have not seen, or I haven't seen them in my case, make any difference in the middle ear. Fair enough, we haven't been doing them that long. So in my hands, it's the one case that I do ask for a CT scan. So if I've got a poorly aerated middle ear, or I've got a strange looking drum, there's always a CT scan that needs to come into that game. And if I do have poor aeration, I will then go for a type 3 tympanoplasty. If I've got good aeration, then I'll possibly try a reconstruction. In terms of how I improve it, absolutely right. You need to check the posterior nasal space. In South Africa, we've got, unfortunately, a high HIV rate, and HIV does give us a high incidence of adenoid regrowth. And we see that a lot of lymphoepithelial hyperplasia around the tuba tubaris. And so that's something that needs to be removed. So I agree with Ian in that case.
That's great. Thank you very much. So I want to go now on to total prostheses, and particularly the issue of footplate stability and what we might do about that. So I think we'll start again with Joachim in Germany. So we've got a situation now where we have a tympanic membrane, we have a malleus, at least a malleus handle anyway, but we have no stapes and no incus. So what are you going to do to try and what prosthesis do you use, and what tricks do you have for stabilizing at the footplate?
Well, this is the tricky situation, and in Chris' presentation, the shoe in different shapes was mentioned. This could be an option, but if we have no stapes, we have a more complex situation. If we look in a setup with a laser Doppler biometry in the temporal bone and look at the vibrations of the footplate, then if we have a stapes, the whole stapes vibrates as a solid body, whereas in a missing stapes superstructure, the footplate is bending through, and you have a maximum at the point where the prosthesis is placed on the footplate, which is sometimes a little bit hilly. And we would try to put the Munich prosthesis on the footplate using this hilly structure for stabilization. And the other end remains also difficult. We looked at Helm's database with a number of 10,000 tympanoplasty, whether there are different results in TORP tympanoplasties depending on the presence of the handle of the malleus or the absence. And it turned out that if we have the handle of the malleus present, which is a little bit surprising, and we use a cartilage palisade technique, which is going back to Hermann and for me extremely difficult to perform, then the presence of the handle of the malleus is audiological better. If we have another technique like a cartilage island technique, as it was described by Glasscock or Milewski, then we have a complete plate of the tympanic membrane with an overlapping pericondylium frame, and that would give a completely different mechanical system, and this is fortunate for the results in TORP tympanoplasty. However, the problem of tilting of the prosthesis is not solved properly if the stapes superstructure is missing.
Okay, and what about using a cartilage shoe? Do you ever do that? Do you cut a little shoe out of cartilage?
Yeah, we used the cartilage shoe, but in my experience, it did not help to stabilize the prosthesis. That was described by Hüttenbrink, but it might be an option in a way that Helms and Blinsky described it. If the footplate is missing, then you reconstruct the footplate with the cartilage shoe, and then this helps stabilization. If we fill up the oval niche with cartilage, this will result, to my experience, in a very few cases, to fibrosis and scar tissue in the middle ear. So this is not really an option.
So we've
situation
established
where we
now
have
that
the situation where we have
so we've
a stable
established.
superstructure missing.
Yeah.
Sorry.
Yeah. Yeah, I was going to say we've established now that in some respects a total prosthesis with no stapes is more tricky because we've got to stabilize laterally and medially. So what chances of good hearing do you say to your patients? What's the chance of them getting a hearing within, I mean, we tend to talk about within 20 decibels. So the patient's got a ventilated ear, a malleus handle, but no foot plate. What are the odds of them getting decent hearing, would you say?
Well, if I go back to the database, what we found out is, depending also on the situation, what happened to the mastoid in a situation where we have no stapes superstructure, roughly 45% of the patients with a cartilage plate and an overlapping pericondium frame with a TORP prosthesis end up within 10 dB, and about 52% within 20 dB, and 48 to 50% are worse than that. So I say the patient, the chance is 50-50 for having an outcome within a positive tuning fork test according to Rinne afterwards. And depending on the situation, if you have a drilled out mastoid.
Yeah.
I cannot hear you.
Sorry. In Germany, the states are prepared to pay for an operation which has got a 50% chance of success. To which country, I guess, Germany. Yeah. So we're going to go on now and just try and get some tips on the foot plate stability. So we're going to go to Zhao in China. Could you tell us what tricks you might have to help stabilize the foot plate, the prosthesis on the foot plate? So it's a total prosthesis going onto a mobile foot plate with no stapes superstructure. Do you have any tricks for helping with stability?
Thank you. Actually, it's a challenging. As we know, the hearing result the hearing result for TOP is not as good as for POP. So that is because caused by the good position of the top. So as my experience, when I put the top in the right position and I put some sponge around it, and I use some cartilage on the top underneath the eardrum to make the position fixed. I think as it grew, the top will lie on the eardrum and make the position better. So do I.
Okay, thank you. That's clear. So you use sponge to stabilize it in the short term, and then if you get the length right and the cartilage is good, then it's stable long term. Yeah. Ian, what about you? What do you use any tricks on the foot plate?
I've used the Omega shoe, but sometimes I find that can be a very tricky little beast that will bounce around the middle ear at times. I've tried the cartilage graft. Again, I would reiterate what Joachim says and you, that the results are not so good with torps, and you want to have the optimum middle ear conditions with a nice middle ear depth and a good eustachian tube function if you're to stand really any chance at all with a torp. And I would say I would consider a hearing aid for these patients. I would counsel them and say a hearing aid may give them actually a very good result. And I think bearing in mind that this is going worldwide where the health economics may not allow for complex PORP and TORP purchase, that hearing aids may be a better and cheaper option for their patients that give the patient good rehabilitation.
So Robert, You've looked a lot at this stability and with your malleus relocation. Perhaps you can tell us a little bit about that and how you do it, because I think quite a lot of the audience will not be aware of this technique. So you can perhaps describe why you used it and how it's helpful.
The
how
point
you do
is, the point is that we very often have a gap between more or less really anterior malleus and the stapes head. There's always a difference. So the point is that to reposition the malleus, to place it over the stapes head in order to have at the end a vertical position of a prosthesis, whatever prosthesis you use, including incus transposition. That is the point. So to do this, the first step is to dissect the malleus sandal. So I do an incision through the periosteal of the malleus, and I want to separate entirely the malleus from the tympanic membrane, including the neck of the malleus. That's an important step. And to do this, it's always better when the incus is there, not to remove the incus immediately, because the incus will give me some resistance to do this, and it helps for dissecting the malleus sandal. So that is the first step. The second step, then I remove the incus, and then at that stage, the malleus is only attached by the superior tympanomallear ligament and the anterior tympanomallear ligament. So we need to overstretch the anterior tympanomallear ligament. So I will use a hook, and I place the hook anterior to the malleus, and I pull the malleus backwards like this until I reach the resistance of the anterior tympanomallear ligament. And then I need to overstretch the anterior mallear ligament, and then I can place the malleus over the stapes head. And you need also to cut the tensotympanoid tendon.
Can we open it out a little bit?
Do you do anything to? Yeah, okay, John. Why don't you do that? Let's have some questions from the Zoom room.
Yeah, I mean, these are very sensible questions that are coming in. There's one here from Reda Almeria. What is your definition of successful ossiculoplasty surgery audiologically? Maybe we can ask the panel.
But I can start because my microphone is still on.
Yeah.
We generally, when we look to the literature, we say airborne gap closure within 20 dB seems to be the definition for success rate. But to be honest, I don't think it's the right way. We should say 10 dB also, but it's also depending on the opposite ear. It's different in stapedotomy, but I think 10 dB would be the honest position for that, which is difficult to achieve on ossiculoplasty. That's my own position.
Okay, can we ask you, Zhao, in China, so what would you be happy with as a surgeon, as a successful result, and how do you discuss that with the patients, what they can expect from the surgery? You.
For the patient who receives POP, we can tell the patient you can get better hearing with AP gap maybe lower than 20 or 15 decibels. But for patients receive POP, we said maybe the AP gap under 20 to 25 is okay. Frankly speaking, that the top reconstruction results is not as good as POP, and it's not as perfect as the POP's results for us.
Okay, and so Meenesh, you've been on the chat room, and you've also got a lot of experience in India. What's your feeling about success rates when you're talking to your patients? You know, they want to know, should they have a hearing aid? What's the chance of them getting decent hearing, perhaps both with and without a stapes? What do you tell them?
Well, there are three things in India. You know, it's a multidimensional thing. One is, of course, in all setups, the government or the insurance companies, it's a little different, do not pay for the prosthesis. So if the finances are limited, the patients actually want a better result if they're using a prosthesis. So sometimes it's very difficult to explain to them when it comes to the extrusion rate. So even if there is a 5% extrusion rate, sometimes patients might not accept it. But on the other hand, the good thing is, I have seen that even though, as Professor Roberts said, that the 20 decibel is something which is acceptable, we have patients who are having 25 or 30 decibel and are still relatively happy. But what I usually try to do is try to explain to them that, you know, we have different options. So most patients in India actually go for the safer option and accept a little less hearing in that ear, provided the other ear is normal, so they don't mind it.
Good. Thanks very much. I'm going to go back, take this back to Duane, and just slightly change the question. Where I'm going to try and bring. Oh, here we go, Duane. So it's sort of just turning that round slightly, and it's looking at your results. But what's the minimum airborne gap you would consider operating purely for hearing improvement on a patient with no stapes? So that means looking at your own results, knowing what your figures are. When do you say actually your airborne gap's 15 dB, we're going to leave you alone? What sort of level are you talking about here?
I would say if we're doing just a primary ossiculoplasty, well, with no stapes, I'd need an airborne gap of more than 30 to 35 decibels. And as I think Meenesh said correctly, 25, in my hands, I was looking at the results, it's between 28 and 13 without a stapes, which I was very happy with, but that's on this little study that I've just done with the cement that we're using. Just if I can backtrack a second, Chris, stabilization of the foot, your torque on the foot plate has been my biggest problem, and that has moved a lot. And so we are busy, well, maybe I shouldn't put it out there because we're still busy with it, but we're putting a very small amount of ossicular cement. You've got to be very careful that you don't cause fixation of the foot plate with this. Then using a little nylon core and bringing that up, and that seems to be sitting and staying, although we've only got about an 18-month follow-up on this. So in those cases, I have seen it go below 20 decibels. And so I would still say that a patient needs to get at least 15 decibels hearing improvement for them to feel that there was a success. So if that's the case, and I'm aiming for less than 20, I'm probably going to get lucky if I get 20, I would say I need 35 decibels at least. Sorry for the long answer.
So a really good ongoing, a big airborne gap. Now,
there's a question for you here. Can we ask it from the Zoom room?
Yes, of course. Please do.
Yes. Well, there's a question for you and, of course, all the panelists. It has two parts. One is, of course, what is your experience with the Méliès replacement prosthesis which you did? And to all the panelists, in a case of cholesteatoma, would you actually put on a titanium prosthesis or would you like to stage it?
Right. The Méliès replacement prosthesis I was going to come on to a little bit later because it's sort of a more advanced technique. But in my experience with cholesteatoma, I always do the surgery as single stage. We'll talk about cholesteatoma later today, but I do a primary bony obliteration of the mastoid, and I always reconstruct the ossicular chain. I follow my patients at 1 year and 5 year with a diffusion weighted MRI scan, and I'm quite happy because of the scanning. I'm quite happy that I don't need a second look. And I also found that by doing a primary reconstruction of the ossicular chain, it helps my tympanic membrane reconstruction as well, because it gives a bit of stability to that. So, but that's a great question, and I think maybe we should take that across the panel and see what other people think. I think we'll stick with the cholesteatoma for now, and we'll come on to the Méliès replacement prosthesis later on, if that's okay. So let's go to, I think we'll go over to Joachim and ask about that. So what do you do in the case of an ossicular discontinuity in the presence of cholesteatoma? Do you stage your surgery or do you do it as a single stage, Joachim?
Well, first we should differentiate which type of cholesteatoma it is, but this has an impact on the...
Well, let's just make it awkward, and let's just say the cholesteatoma is actually onto the ossicular chain and down onto the stapes. So you definitely have some concern about that.
So we would remove the ossicular chain and the cholesteatoma, and we would reconstruct the ossicular chain at one stage. We would not stage for ossicular reconstruction the surgery. Maybe an exception would be if we have a fistula at the foot plate or a fracture down at the foot plate where we are not sure if the situation is stable and we would fear a penetration of a torp into the vestibule. But in the other cases, we would do it in one stage. And regarding the database that I have mentioned, maybe 75% of the patients have an acceptable outcome and would not need a second intervention. However, as you mentioned, MRI in the follow-up will modify our procedures in the future and give options to also look at the ossicular chain if we have a reason for a second look, which we also would not
Okay.
plan on a primary attempt.
Can I just ask the panel, who most of whom I've got on the Zoom, if any of them stage their surgery so that they do ossiculoplasty at a second stage? What about in China? Is everything in China, is everything done as a single stage? Osteotoma surgery.
Actually, because in China there's a lot of cholesteatoma patients, so
Yep.
We usually face this question. I will tell patients, we do one-stage surgery for you, but if the post-surgery hearing result is not good, is not satisfied, especially when we have a bigger AP gap, we can have a second look. And I will tell the patients, usually the international rule for this kind of surgery usually have second look surgery, but we usually do one-stage surgery. If you have chance to have second look, that's just you do nothing. You do nothing. You just have more opportunity. But as a result, for patient who received one-stage surgery, more than half of them have good result hearing, good hearing result. So only maybe less than 10% patient need second look.
That's good. Ian, I see you had your hand up. Let's just have a chat from Ian. Were you going to comment on that, on cholesteatoma surgery and ossiculoplasty?
Yeah, well, when I started operating as a consultant, the DWI MRI wasn't available, so I tended to do a stage second look, because really what I wanted to see was what was happening to middle ear depth and whether there was any further retraction. But now we've got DWI, I will try to reconstruct primarily if possible.
Right,
Okay.
Chris, I think we need to go a little bit out into the Zoom room.
Let's do that. Yep.
There are a couple of things, there's a couple of good questions here, and I suppose this applies to the Eastern world and some of the Western world, and that is there's an ongoing cost implication of wearing hearing aids, and they're quite expensive, and actually in some parts of the world having surgery is cheaper. Now in North America, for instance, hearing aids are not covered, I believe, by the medical insurers, but surgery is. So whilst many of us would offer hearing aids because in the good old UK they're very cheap, obviously that doesn't apply, for instance, in India, I believe, because they're quite expensive. Does anybody have any comment on that?
You need a comment from India?
Yeah.
Okay. Yeah. Well, that's true. That's true. You know, hearing aids are expensive in India, and in places like India and China, we do see a lot of cholesteatoma. So sometimes post-surgery patients do not complain too much if the other ear is normal. And with the insurance, the problem is they do not cover hearing aids, they do not cover the prosthesis. So both are not covered by the insurance. So the patient has to pay for both of it.
In the long term, Meenesh, which works out cheaper?
For me, maybe the surgery. For the patient, I don't know, but I think maybe there are. No, the thing is, a lot depends on a few factors which I analyzed when I was working in the medical school. It depended on the age of the patient, it depended on his profession and the condition of the other ear. I have seen in Mumbai or Bombay, where I practice, about 50% of the patients were happy with about 30 or 35% airborne gap in one ear if the other ear was normal. They said they didn't really want to go for another surgery. They were happy with it. But of course, that's not the case in the West.
Okay. Now, we'll put this back to the panel in a minute. There's Tariq Hamid coming in here. His question is, I notice that when I operate on a patient with bilateral conductive hearing loss, either performing stapedectomy or ossiculoplasty, in many of the cases, there's some sort of improvement in the airborne gap in the non-operated ear. Does anybody on the panel have a scientific explanation?
Could that be a masking dilemma of the original audiogram?
Yeah, I think that's probably the case. What do other people think?
I would go with that. I think it's a masking dilemma because we do see that.
Yeah, it's not something I've seen, and I don't think you're genuinely changing the hearing in the non-operated ear. I don't see how that's going to happen. Have you got any other questions from the Zoom room, John?
Yes, I've got lots. My question for Dr. Robert Vincent, is there any long-term effect of malleus relocation in terms of weakening of the malleus, failure, or its blood supply?
So I never had any malleus necrosis. That's the point. Sometimes I had problems of fixation of the malleus at the beginning of this technique when I was introducing this technique. It was because I didn't take care of leaving some gap between the neck of the malleus, of the head of the malleus, and the posterior part of the bony canal wall. So now I know this, and just before doing the malleus relocation, if there is a small canal, then I use the curette to make a small gap to increase the distance from malleus to the bony canal wall. But I never had any problem with that after that.
Good. And then we've got a question as well from Michael Waring to the whole panel. This was rather earlier on. Obviously, there's some variability in results related to eustachian tube dysfunction. Do the panel put ventilation tubes in sometimes when they're performing ossiculoplasty? Mike's there. I can unmask him.
Let's get Mike. You can ask a question. Do you do that,
yeah,
Mike?
No, not usually. I mean, but the problem is that even if you follow up your ossiculoplasty patients, sometimes you get good results and sometimes you get bad results in the same patient, depending upon the status of their middle ear. Often these patients, their eustachian tube dysfunction is not resolved by your surgery.
Yeah, I mean that's the point.
I'm sure everyone must have noticed that when the patient comes back, the hearing result is not the same at 3 months, 6 months, a year. Sometimes it can get better.
Yeah, I think that's if you want good results, you pick nice patients with well-ventilated ears, isolated ossicular defects, you'll get great results. A lot of us with the sort of practice where we're dealing, as in China and India, with a lot of cholesteatoma patients, poor eustachian tube function, then the results reflect that, I think. And I think we can all reassure ourselves that when we get poor results, we're not on our own. The ears are tricky sometimes, in spite of good surgery.
I have a question here which has come from the WhatsApp because it's not been seen here. Can I put it forth?
Yeah, please do. Please do.
Yeah, it's an interesting question to all the panelists. It says that Professor Vincent has come out with great prosthesis. All of us are doing a great amount of ossiculoplasties. Do you see a big role of bone cement or hydroxyapatite bone cement in ossiculoplasty in the future? And all of us are doing it, including Duane. So maybe you can put forth the question to everyone.
Well, Duane, I think would be good to talk about this because I know Duane's a big fan of cement. So maybe you can tell us your experience, Duane.
So it all started, and I think this is a similar situation in India, is that the prostheses are sometimes not covered by the medical aid funders. And so our patients are having to pay quite a lot for the prostheses. So we started using, initially I started with hydroxyapatite cement. I don't want to name any company names or anything, but the cement for me was boggy, took long to dry, and wasn't very. It didn't feel like it stuck nicely. And so and correct me if I'm wrong. I'm sure you guys have maybe got better experience with that. But the glass ionomer cement that we then pursued, we took a specific one and we looked into it, did a whole lot of tests on it, and we actually got a very, very nice manipulative tool to reconstruct, the ossicles with this. And so I use a lot of cement in my surgery. I don't want it to be used as a sort of a scapegoat when you've made a mistake or something has come loose. You want to use it as a primary. And we found that just putting cement there, it did break and it did fracture. But we've now used a nylon core for most of our reconstruction. So we just take a 4/0 nylon, cut it to the right desired distance. Maybe if we're doing an incostapedial joint disassociation, just put a little 2-3 millimeter little core there and then cement around it. And we're finding that these are being a lot more stable. We've only been doing this for about 7 years, the core technique. So we haven't got that much data on it. But so from my point of view, I think cement, well, at the moment I'm testing a lot of other things with the cement, so I think there is a future for the cement. I haven't yet seen too many complications. Maybe I'm just the guy that's trying to reinvent the wheel and I'm going to get smacked on the head.
Duane, how do you think it's important to make sure you dry the incudial remnant before you apply the cement?
So we found with the hydroxyapatite that is an essential thing. However, I'm using a thing called Ketachem, similar to what Levent Sinaroglu in Turkey uses, and we don't need to dry it that much. Or put it this way, it's glued very well even in the presence of moisture. As a rule, I try and make the ossicles as dry as possible, the reconstruction surface. But I mean, we've actually tested it in a few other things, a few other patients, and we haven't had it loosening, even though it was on a wet surface, because that is a difficult thing to try and get that ossicle perfectly dry.
Yes, one point, we of course, we can also ask the question from Germany, is that the question asked is, in view of a successful ossicular reconstruction, maybe we can start from Professor Vincent also, in view of a successful ossicular reconstruction, what in all the panelists' view is the most important? Is it the eustachian tube? Is it the tympanic membrane? Is it the middle mucosa? Age of the patient? What do you think are most important factors for a successful reconstruction result?
Well, to give just a comment to the question of the cement, I think there is a future, but maybe limited. I understand that Duane is a fan of the cement because the Ketachem comes from South Africa and was looked at by my co-worker Gaia and my teacher in the end of the 90s more closely. And the expectations we had in the beginning were not completely fulfilled, but in the modifications that Duane has introduced, I think there is a future, but the indication will be limited to well-selected cases, and then the core may open a real option. And I'm looking forward to look with Duane more closely scientifically in this project that we hopefully get to run. And coming to the question of successful ossiculoplasty, I think it's a combination of everything. It's a combination of the aeration of the middle ear cavity, of the proportions of the handle of the malleus, the tympanic membrane, the remnants of the ossicular chain, and the situation of the mucosa. And depending on that, you mechanically can interpose the defect. And Robert showed in the model in the beginning very nicely when he attached the prosthesis to the stapes that it was perpendicular onto the footplate, and this gives a similar mechanical reconstruction as we see it in birds, and this may contribute to the success if the ear is aerated and the mucosal conditions are fine.
That's true.
So it's not a single point.
It's
Robert,
spring
sorry.
now, and in South of France we have a lot of birds there. This is the reason why I move on to this direction of new techniques.
I think on that point, there are a number of people over the years who've looked at a variety of different issues. So Bruce Black in Brisbane with his spite index and Jack Cartouche with his index, where they score a whole variety of things, including the eustachian tube function, the quality of the middle ear mucosa, whether there's osteotoma, whether there's infection, what the ossicular status is. And if you add up all those things, if you have no ventilation, no ossicular chain, you've got infection, those patients will do badly. And the patients with a nice normal tympanic membrane with a ventilated ear and mobile stapes are going to do well. So it's a combination, it's just as Joachim said, it's a combination of those things. And the literature, a number of people have looked at that over the years.
I think it's very true, the old adage that the eustachian tube's a bit like the coloproctologist. He'll always get you in the end, if you get that. Do any of you guys pay a lot of attention to the nose before you...
John, can you explain your last remark? John, can you explain the last remark? I didn't understand it completely.
I think you understand. I think you understood that, Wilco. We say the eustachian tube will get you in the end. if it's poor. It's a bit like the coloproctologist, which I think you all understand. But what I was trying to say is, if you have a patient who comes along with rhinological problems, do you get either yourself or your rhinological colleague to pay attention to those before you perform middle ear surgery, or don't you believe it makes a huge difference?
Ian, maybe you'd like to comment on that one.
Yeah, well, I did mention this earlier on, John, where I think it's important with any patient with chronic ear disease to endoscopically assess the nose and postnasal space, because personally over the years I've seen a number of patients that still have residual adenoid tissue completely obstructing the eustachian tube. And as we've discussed, the ventilation's most important thing, I think, to getting a good surgical result. So I think we need to address the nose and the postnasal space in every patient, or at least have a look.
So I think, John, that stuff about the nose, that was when you were sleeping earlier on. We had a bit of a chat about that.
Probably was. And there's another question that's come in here, which I suspect we know the answer to. What about ossiculoplasty in pregnant women and risk to the pregnancy?
So generally in the UK, we try not to avoid on pregnant women. You've got to bear in mind this is elective surgery. There's no urgency for it. So we would normally say, come back with your baby, and then we'll get you. You'll be pleased initially with the baby that you can't hear it cry. So probably wait a couple of years until it stops crying, and then have your operation. I don't know what about
Chris. Who would operate on a pregnant woman for ossiculoplasty?
Don't know. I've no
on the
idea.
woman or on the baby?
Maybe somebody on the local might consider it, but I certainly wouldn't.
But there's no real urgency to doing it, and I think you'd be well advised not to. Any other questions?
There's an interesting question here.
Thanks, Meenesh.
Would you find it necessary to address the mastoid in case of an ossicular necrosis in ossiculoplasty? Would you think it's important or necessary as of today?
Okay, let's go to Yu in China and see what he thinks about that. So question, Yu, is if you've got an eroded incus, what do you do in these cases regarding the mastoid? Do you image the mastoid? Do you do a mastoidectomy, or do you just repair the incus?
If I'm sorry, you mean if the incus erode? What?
So it's a patient with a retracted eardrum, and they have an eroded incus. And the question from the Zoom room, from the attendees, what do you do with the mastoid?
Yes, is it required to explore the mastoid?
Okay, I know. I don't think the mastoid is get responsible for the retraction with a key factor. So for this patient, if we remove the residual of the incus and rebuild the eardrum with cartilage and with a pop on the stabias, sometimes we have a mastoid. We drill the mastoid process, but I don't think it works much good result for the function of eustachian tube and the middle ear cavity.
Okay, thanks very much. Maybe we can take that over to Joachim. What do you think about the role of the mastoid in routine ossicular surgery? Do you operate on the mastoid? I'm just trying to get you back.
Well, I think this would be a good discussion for hours. In one of the next panels. We tried to answer this question when comparing Hildmann and Helm's data. One did always androtomy and exposing the mastoid, and the other did not. But we did not find any differences in comparable cases, so we were simply not able scientifically to answer this question. I mean, this discussion brings us to the function of the mucosa and of the mastoid. Is it diseased, or is it producing and taking part in the gas exchange of the middle ear and the antrum? Maybe an attempt to
Maybe we should discuss that in the mastoid roundtable later today. That might be a useful time to discuss that, I think.
I mean,
There's one question
if you
from
think about
Dr.
Takahashi's work, where he showed the aeration of the mastoid after tympanoplasty procedures, this clearly supports the idea that the mucosa is participating in the gas exchange. But maybe for a practical access, if you look at a high resolution CT scan of good quality, you may see Kerner septum or a blocked antrum. And in these cases, I would consider, with a knowledge of the early studies, that this could be cases where exposing the mastoid and creating a drainage from the mastoid to the middle ear and the Eustachian tube would be an attempt to give some benefits to the patients. But, well, clearly we need more data.
Okay, so we're going to go back to Meenesh and ask if there are any more questions from the Zoom room.
There's a question from Dr. Prakash Munka, who is a senior otologist in India. He asks all the panelists, starting from Professor Vincent, for all the prostheses you use, is there an age where you can start using it?
No specific age. I've used it. I was using it also for some cases of congenital malformation in a very young patient, like a 7-year-old, and there's no contraindication for that. It works fine. Sometimes the only thing is that, and that's the beauty of hydroxyapatite. When you do congenital malformation on a young child, sometimes you have a very tricky situation with a very narrow middle ear space. And of course, narrow canal. So in that case, you need to change the shape of the prosthesis by reducing the size of the prosthesis head. And then if you use hydroxyapatite head prosthesis, just like bone, you can drill out and reshape completely the prosthesis head. Once you cannot do that with a titanium. This is why I'm using a HA.
Does anyone else have any other opinion on this point?
I mean, I use the all the prostheses, irrespective of age. I agree when it's on young children with cholesteatoma. I tend not to operate on very young children with congenital problems because I like them to be part of the discussion. But if it's a young child with cholesteatoma where I'm doing an ossiculoplasty, I would do exactly the same as I do in an adult. And the middle ear is usually remarkably similar, although I accept that the canal is often smaller and they maybe need a canalplasty. I think the longevity of the prostheses are good. The titanium, as long as the ear is ventilated and you've got cartilage, they don't come out. But I also think that if you've got very poor eustachian tube function, most of the prostheses can extrude over time. I don't know what other...
Thank you. There's another good question here. There have been some reports about a procedure called soft wall reconstruction. Reconstruction of the posterior canal wall in a case for cholesteatoma as an option to the cavity obliteration, and apparently it helps in increasing the middle ear space. So, have any of you have any experience of a soft wall reconstruction before doing an ossiculoplasty?
I think, Meenesh, I'd quite like to leave the reconstruction side of the canal and the mastoid for this afternoon, because we've got a session on mastoidectomy. And I'd quite like, if we can, to take I know there have been quite a lot of questions about Robert's malleus replacement prostheses.
Yes.
But if there's anything else more ossicular? Yeah.
Yes, there's one question is about, Robert, is that whenever you have doing a malleus relocation procedure, is there any weakening or failure of malleus in the long term?
Yeah, I think he's addressed that one.
Meenesh, can I ask you?
I covered that earlier.
I didn't have experience like this. I didn't have any problems with malleus necrosis. I experienced now many years. If I come back to the question of results, I have published, I know Michael Waring just asked me the question like this. I have published my results for malleus, both for malleus replacement prosthesis comparing with previous tympanic membrane to foot plate and malleus replacement prosthesis to foot plate, and also for sylastic bending. So if you go to otology, neurotology, you'll find my results. But it's statistically significant in terms of success rate. When I compare my results from tympanic membrane to foot plate compared to malleus replacement prosthesis to foot plate in Austin cartouche group D, which means absence of malleus and absence of stapes superstructure, I got something like, after 1 year, of something like less than 30% of success rate. When I was not using MRP, and when I'm using the malleus replacement prosthesis, it was up to 80%, which was really Very interesting.
And what about a lot of people have been asking about the long-term results of the MRP, Robert.
Yeah.
You're the only one who's got those results, really.
That's right. I need to publish that. The problem is that I had cases of extrusion, not because of a problem of the procedure itself, but because at the beginning I was not covering widely the prosthetic titanium with cartilage. Now I'm enlarging a little bit the size of cartilage, so it's getting better. But it seems to be pretty stable. But of course, I need to go into my numbers and to say the truth, because I don't want to say any number now. But it seems to be quite stable.
If you're given the choice between a malleus that you could replace, so they've got the malleus, and you could replace the malleus, or you could use your malleus replacement prosthesis. Forgetting money, if it's just a choice between the two, which would you prefer?
Well, if the malleus is there, I would use the malleus for sure. But sometimes you have a malleus which is there, but you have a loose malleus, you know, floating like this. So in that case, I don't use the malleus and I use the MRP.
But is that because the malleus replacement is better, or it's just because it's cheaper?
No. I think if the malleus is there and
that's
fine,
the best. That's the best. Use it.
Yeah.
Okay.
There's an interesting question.
Meenesh, one moment. Meenesh, please keep the mouth microphone distance a little bit further away, because it distorts all the time. It'd be better if you don't. Thanks.
Yeah, now it's better.
Meenesh, you put your question, Meenesh. I'll put mine afterwards.
Here is, how do you know the exact thickness of the cartilage to be placed above the titanium prosthesis? I mean, there are various cartilage slicers which are present. Some people do it only with a blade. So how do you measure it, or is it just an experience?
I think for me, it's just an experience, but.
Do you use a slicer, Robert, or do you do it manually?
No, I do it manually, but I think slicer would be very nice, but I don't use it.
Yeah,
so how do you guys that use the slicer get around the problem of the cartilage curling? You know, I have two cartilage slicers. Both of them, even when it's quite thin, it still tends to curve. I mean, sometimes that can play in your favour, but does anybody have a solution for that?
You need to take the middle part.
We can ask Joachim.
Yeah.
Do you use a cartilage slicer, Joachim?
No, we slice with a blade 11, but there are from Germany investigations on the thickness of the cartilage, and in the end it depends what you want to achieve. If you want to have a vibration very similar to a normal tympanic membrane, then to my knowledge a thickness of 500 to 700 microns would be ideal. If we have to support the tympanic membrane and have a handle of the malleus present, then the thickness of the handle of the malleus would be the thickness we should shape the cartilage, so that we have a plate for the prosthesis and one plane between the handle of the malleus and the cartilage placed aside of the handle of the malleus, and that should fit ideally in the remnant of the tympanic membrane. But however, if we discuss cartilage as a replacement material, we are in a completely different mechanical model compared to what the normal tympanic membrane should give, and that should be considered when introducing cartilage, which is stiffer, it's more heavy, and that should be weighted with the advantages and the disadvantages in reconstruction.
Okay, John, have you got any more questions coming in, or anything coming out of the polls? John, if you just unmute.
Yeah, one is coming in for all the experts from Kazim Janabi. Please could the experts tell me how they manage the plastered eardrum? I presume he means the eardrum that's plastered to the medial wall of the middle ear.
Okay, I think maybe we'll ask
Can
Robert
you repeat
that,
the question? I could not hear properly.
So the question is, how do you manage the situation where the eardrum is completely plastered to the medial wall of the middle ear with no ventilation? And the reason I ask you, Robert, I've never ever seen you do one of these, because you always have such beautiful ventilated ears in Béziers.
Yeah.
So do you, my feeling in the past is you would have phoned up Benoit Graticap and said, Benoit, I've got a case for you. But what would you do? What do you do for those in Béziers?
Yeah, that's exactly what I would do.
Yeah.
But how to you, Chris? I don't think it works. I've done cases like this, and you spend a long time to, you know, re-elevate, dissecting the tympanic membrane and putting some elastic sheet in the middle ear to avoid any recurrence. But then it does recur when you have a poor statutory function. So I don't. If there is no air around the tympanic membrane, then it does not work. But once you have some air around, then I think you can do it.
Okay, so a hearing aid's a good option for those patients, I think. What about
or move from Slough to the southwest of France would be probably a much more sensible move.
I have to say, I remember years ago having a patient who had problems with his nose being a bit blocked, and he said when he was in Switzerland skiing he didn't have a problem. I said, well, why didn't you just move to Switzerland? So he did. He sold his house and he moved to Switzerland and he was fine. So that's what happens with your Windsor patients. Anybody got any thoughts about tips for those? I mean, my feeling is that really you should only operate on those if they get problems with either cholesteatoma or with recurrent infection. So to operate on those plastered ears for hearing is usually not a great option, and very often they have quite good hearing anyway. Any other thoughts from the panel? You in China, do you take these cases on?
Oh, I know its time is up, but could I have a question? Have a new question?
Yes, let's hear your question. Let's hear the question.
I have a patient. I had a patient. The patient has the gradually decreasing of hearing for 4 years, but in the surgery we found the superstructure of the stapes separated from the footplate. It just be observed under endoscope. We can find the very tiny lesion. And interesting, the history of the patient, 4 years before the hearing decrease, he had an emotional accident, and after that, the hearing decreased. So when we have surgery, the superstructure separated from the footplate. I want to ask, sirs, if you have some such patients, and what do you think about etiology?
Yes, I've seen exactly that situation where patients had some trauma, and then when you've explored it, they've had a mobile footplate but a dislocated superstructure, and I think they probably have a congenitally slightly thin. Bear in mind, from the embryology, the footplate and the superstructure are separate, so that they're just not very closely adhered, and then it dislocates with the trauma. And with those, you can put a stapes prosthesis from the incus down onto the footplate if you get the length right, or you could. So I think that's quite a nice option. I'm sure some of the others will have seen that as well.
I had cases like this and post-trauma. A very interesting thing is that you can make the diagnosis sometime when you do the audiometric test. You have persistent staphylococcus reflex. With airborne gap following trauma, it's very frequently associated with fracture of the stapes superstructure. And in that case, if the incus is there, I put a piston from the incus to the mobile footplate. But it's pretty difficult, because then when you do a stapedotomy, when you have a fixed stapes, it's not so complicated, because then you measure the distance, and then you can create the stapedotomy, and then you put the distal tip of the shaft into the stapedotomy. So it's more easy. But when you don't create a stapedotomy because of a mobile footplate, then it's more complicated, because it needs to be absolutely perfectly well done in terms of length. But when you have that, it works very nicely. So I would say keep the stapes superstructure in place, because the superstructure will help you to stabilize the piston, and then put a piston from the incus to the footplate.
Robert, I was going to say, I've seen three of these in my career. 2 of them were skateboarding accidents, which I don't know whether that's relevant, but I'm sort of quite concerned that there's a move at the moment to decide whether people are going to be using electric scooters and push bikes and things in the UK. I'm sure we're going to get a few more head injuries associated with this sort of damage, but definitely you can get very good results if you get the lengths right. I think that's the most important point that you've made.
If you give me a few minutes, I will come back to my database and I will give you my results.
Well, you've got about four. You've got about four. So,
would you consider actually doing a laser stapedotomy and just putting a prosthesis through it? I mean, I did do that. I did that once on a patient who'd had a traumatic stapes fracture.
Michael, it works fine. Yeah. You do stapedotomy. It works fine, of course, because then you stabilize the shaft inside. But the problem is that, and I think it's very safe if you have a laser. But you just have to think about our discussion in front of all the people and a young surgeon. I think it's important. If you have a complication in that kind of patient having a sensory hearing loss, then if the patient sues you, then you have a problem because you explain that you do stapedotomy on a mobile foot plate. So there are two ways of thinking about this. Technically, it works fine, Michael, for sure.
I think what you do in this situation, Robert, is you try what you suggested first. You wake the patient up, and if they can hear okay, that's fine. And then you say to them, I didn't have a preoperative discussion about this very unusual finding. The stapes being fractured, I can go back in. If I do that, I have to do a stapedotomy. And if I do that, there's a slight risk. I think you're safe if you do that. But I would counsel anybody against doing a stapedotomy primarily in that situation.
So you see, I did incus to stapes foot plate, incus to mobile foot plate on 96 cases since now 1991. And in terms of success rate on 86 cases, it was, let me see, in terms of airborne gap closure, within 10 dB, it's 60%. So it's not as good as when you do a stapedotomy.
Chris and you have 3 more minutes, so maybe a summing up might be appropriate.
Yes.
Just the things we've discussed.
Yeah, well, maybe I'll do that. I'd like to thank you, Zhao. I'm sorry about the poor quality of the sound, and I feel slightly bad that I usurped the chair, but I think we've had a great discussion. I've really thoroughly enjoyed it. We've seen for the people watching that there are a variety of different techniques. I would really like to reiterate that one of the most important things is the quality of the ear that you're operating on in terms of tympanic membrane, mucosa, and middle ear ventilation. And some of the techniques that you've seen are great fun to do. They're maybe technically challenging, but if you don't have a ventilated ear, you won't get great results. If you do have a ventilated ear and you have a stapes, for most patients, most people feel that the presence of a stapes helps the overall results. Although you've seen Robert Vincent's lovely results with his malleus banding technique. Things become more tricky when you have a total prosthesis with no stapes, because you have an unstable situation both laterally and medially, and perhaps stability with malleus relocation may help that, and maybe some sort of footplate shoe could be helpful. For those patients with no malleus, the malleus replacement prosthesis is interesting, but the number of cases like that is relatively small. For those of us who are doing cholesteatoma surgery, I think that things have changed, and most people are now doing primary reconstruction because we have the ability to monitor the patients with an MRI scan. And as Zhao was saying, it means that you don't have to do a second operation. And if they don't get a good result, you can always have the option of a second operation. And I think finally, I'd really just like to thank all of my panel, who I think have been extremely helpful. It's been great having Meenesh and John filtering the Zoom rooms. There've been good questions coming in from the Zoom panel, and I'm from the Zoom attendees, and I think they'll be able to ask further questions this afternoon. We're going to take a short commercial break now for 15 minutes, and then we will be back. So I would like you, if possible, to all stay and watch the commercial break, because the companies really allow the whole Lion meeting to function. Without their funding, there would be no meeting, and it's wonderful for us to be able to present these meetings completely free to all of you. I hope you've enjoyed it. Thanks, yes. And thanks to all the panel.
Thank you.
Can I add to what Chris said there?
Thank you all.
Thank you so much.
Can I add to what Chris said there? The companies are making very little at the moment, but they've still, many of them, remained loyal to us. So we would like to remain loyal to them. They're very supportive of this event. Thank you.
Thanks, John. Okay, see you all in 15 minutes. And we have a change of hosts in the Zoom room, and we have some new topics. Bye-bye.
Bye-bye.
Bye-bye. Thank you.
Grace Medical is located in Memphis, Tennessee, home of Elvis Presley, Bill Street, the world's best barbecue, and where all of our middle ear prostheses, specialty instrumentation, and ventilation tubes are manufactured. We're an otology-focused company who prides itself in offering the latest designs and technology to treat diseases of the middle ear. Our goal is to reach out and meet the needs of surgeons from around the globe to make sure not only the surgeon, but also the patient has the best care and best possible outcome. Most of the products you will see in this presentation were designed in conjunction with surgeons to fill an unmet need. Grace Medical is built on the foundation of collaborative efforts between surgeons and our outstanding team of product development engineers. We are delighted and honored to be a part of today's line course, which is such a prestigious gathering of some of today's most influential leaders in the field. Our flagship product is our adjustable length implant system, known as the Alto system. This is a patented system that allows the surgeon to measure with disposable sizers, precisely adjust the length of the prosthesis, and then trim to the desired length, all prior to removing the implant from the adjuster body. Because of the unique design of our implants, the surgeon can resize the implant if necessary, even after trimming and removing the implant from the adjuster body. This helps to reduce waste and eliminate the cost of opening a new implant. Here's the system shown. Your disposable sizers will open. You remove your disposable sizer and place on the ossicles to gauge the proper length. Here are 2.5 sizers being used to gauge the length. Once you have the length, you then measure your prosthesis to the desired length, which is 2.5. Trim the excess shaft, remove, and then implant. Our Alto implants are offered in a wide range of designs and materials to best suit the needs of the surgeon. The implants are composed of titanium, hydroxyapatite, or a combination of the two materials. They are offered in centered, offset, and also malleus supporting head designs. One of our latest innovations is the Alto Concise Partial, which is offered in a centered or offset titanium head. The Alto Concise has a functional length range of 5.75 millimeters all the way down to 0.75 millimeters. Another feature of the Alto Concise is the multi-directional head movement. This allows the head of the implant to adapt to a healing tympanic membrane. One of our more unique and popular implants is the Vincent Total with Band. This product is the result of a great collaboration with Dr. Robert Vincent. His design requires some innovative hydroxyapatite machining. In addition to a small flexible band, we were able to produce in our silicone molding room. The result is a prosthesis that has been used to help restore hearing in patients throughout the world. Grace Medical is located in Memphis, Tennessee, home of Elvis Presley, Bill Street, the world's best barbecue, and where all of our middle ear prostheses, specialty instrumentation, and ventilation tubes are manufactured. We're an otology-focused company who prides itself in offering the latest designs and technology to treat diseases of the middle ear. Our goal is to reach out and meet the needs of surgeons from around the globe to make sure not only the surgeon, but also the patient has the best care and best possible outcome. Most of the products you will see in this presentation were designed in conjunction with surgeons to fill an unmet need. Grace Medical is built on the foundation of collaborative efforts between surgeons and our outstanding team of product development engineers. We are delighted and honored to be a part of today's line course, which is such a prestigious gathering of some of today's most influential leaders in the field. Our flagship product is our adjustable length implant system, known as the Alto system. This is a patented system that allows the surgeon to measure with disposable sizers, precisely adjust the length of the prosthesis, and then trim to the desired length, all prior to removing the implant from the adjuster body. Because of the unique design of our implants, the surgeon can resize the implant if necessary, even after trimming and removing the implant from the adjuster body. This helps to reduce waste and eliminate the cost of opening a new implant. Here's the system shown. Your disposable sizers will open. You remove your disposable sizer and place on the ossicles to gauge the proper length. Here are 2.5 sizers being used to gauge the length. Once you have the length, you then measure your prosthesis to the desired length, which is 2.5. Trim the excess shaft, remove, and then implant. Our Alto implants are offered in a wide range of designs and materials to best suit the needs of the surgeon. The implants are composed of titanium, hydroxyapatite, or a combination of the two materials. They are offered in centered, offset, and also malleus supporting head designs. One of our latest innovations is the Alto Concise Partial, which is offered in a centered or offset titanium head. The Alto Concise has a functional length range of 5.75 millimeters all the way down to 0.75 millimeters. Another feature of the Alto Concise is the multi-directional head movement. This allows the head of the implant to adapt to a healing tympanic membrane. One of our more unique and popular implants is the Vincent Total with Band. This product is a result of a great collaboration with Dr. Robert Vincent. His design requires some innovative hydroxyapatite machining. In addition to a small flexible band, we were able to produce in our silicone molding room. The result is a prosthesis that has been used to help restore hearing in patients throughout the world. Grace Medical also manufactures and sells stapes implants for both stapedotomy and stapedectomy procedures. We offer the highest quality pistons and bucket handle prostheses made of titanium, fluoroplastic, Teflon platinum, and nitinol. Our most popular stapes prosthesis is a heat-activated Eclipse piston. From surgeon feedback, we introduced the heat-activated Eclipse flat ribbon piston. The Eclipse flat ribbon piston features a wide ribbon for heat application to help reduce the charring of the incus once heat is applied. The Eclipse malleus piston was designed in conjunction with doctors Marcus Atlas from Australia and Michael Gluth from the US. They performed a temporal bone study and published a journal article on their findings of the anatomical angle between the stapes footplate and malleus. The angle from the study was used in the design of the piston to eliminate the need of bending the piston to perform a malleostapedotomy. The Megarian SRP pictured on the left was designed in conjunction with Dr. Cliff Megarian. The piston offers a solution for revision stapes where the patient still has a usable foreshortened incus. Grace Medical offers the widest range of endoscopic ear instruments in the world and has recently been approved for sale outside of the US. Our designs feature integrated suction to help control bleeding during dissection. We worked in conjunction with the Oates group to produce the most inclusive endoscopic instrument set. One of the main drawbacks of endoscopic ear surgery is a loss of the suction due to holding the endoscope. To address this issue, we introduced the suction dissectors, which essentially puts two instruments into one, allowing the surgeons to simultaneously suction and dissect while using the endoscope. Other key instrumentation requested by surgeons were curved suctions and double-ended dissectors. Each of the suctions feature a unique swivel to help prevent obstruction from the suction tubing. To help aid in the training of up-and-coming surgeons in endoscopic ear surgery, we worked in conjunction with Dr. Matt Dedman at the University of North Carolina to create an endoscopic ear trainer. The trainer comes packaged in a custom case which holds all the components needed to use the trainer. The only item still needed in order to complete the challenges is an endoscope, forceps, and a pick. The user will use the endoscope to complete different challenges. The challenges will help teach dexterity, motor skills, depth perception, use of microinstrumentation, and more surgical skills. This picture shows an internal view of the trainer as the challenge is being completed. Here's a quick video of the Otoskills trainer in use. There's your trainer in the custom case. There's a challenge or module loaded into the system. This is the Lord of the Rings challenge using split washers and forceps, moving the split washers from one set of posts to the next. Stapes challenge using piston-like hardware, place the piston into the fenestration and then onto the incus post. Stake your claim. Use the piston-like hardware once again. Place it into the hole. The key here is to keep the piston remaining upright. Thread the needle. Using glass beads in a forceps, place the glass bead onto the post. Mamadoriyama. Using a hex nut and a pick, push the hex nut all the way up the mountain. This is a maze-like challenge using a pick and a glass bead. Trace the maze with the glass bead. Flying V, using a pick and a washer, push the washer down the module. The goal is to land the washer onto the post. Another maze-like challenge, using a glass bead, push the glass bead around the obstacles, and then the goal is to finish in the opposite corner of which you started. Tabletop games, so you can use the hex nuts and pick to form different structures. You can also use the pick and the hex nut to work on spinning the hex nut as well. Grace Medical also offers a full line of ventilation tubes featuring all popular materials. The Triune tube is a 3-flange intermediate tube. The Triune has a perforation rate of around 3% compared to 16% of a T-tube. A white paper was written comparing grommets, the Triune, and T-tubes. The conclusion of the paper was the Triune offers the best option for both primary and long-term tubes. There are multiple designs in the Triune family, including the tiny Triune and also the Triune trumpet. Here's a quick animation of the Triune tube. As you see here, the tube, you will simply take your forceps and place it inside the lumen. And then you make a standard maryngotomy, and then you push the 3 soft flanges through your maryngotomy. From all of us here at Grace Medical, we once again would like to say thank you for allowing us to be a part of the line course.